Carla Creegan, and I've been a member of the chapel since 1996. And I'm married to Joe, who is works at the church in education. Most of you know him, I'm sure. I've been in the choir since I started with the church, and then I took a sabbatical when I went to nursing school. I've been a nurse since 2006. It's a second career for me, and my specialty is geriatrics. I work for Empath Health, which is a division of Suncoast PACE. I am a Suncoast PACE and Suncoast Hospice. I am a certified hospice and palliative care nurse. But right now I run a program called PACE, which is a program for all-inclusive care of the elderly. So we take care of 325 participants that live in Pinellas County. The mission of our program is to have them age in place. So we provide things like home care. We have an adult day center and social workers and things like that. Everything you might need for your elderly parents to stay in their home. I've also done oncology nursing, and I worked at Baycare on the cardiac floor. So that's me. How about you, Lurane?
I'm currently not working as a registered nurse. I do have 10 years of experience prior to this in community health. And then the 10 years prior to that, and that 10 years was primarily in the U.S. Virgin Islands in a community health setting. The 10 years prior to that was as a public health educator in a county health department. So some of that I think is particular or hopefully pertinent to discussions related to COVID and community health. Thank you.
Definitely, definitely. Sharon?
Hi, I'm Sharon Sullivan, and my husband Brian is the treasurer of Chapel by the Sea. I've been a nurse since 1997. My experience has all been in dialysis, so I don't have much to offer. I kind of logged in to listen, give my opinion of going back to church.
Okay. All right, Cindy?
Hey, I'm Cindy Owens. I've been a member of the chapel for 20 years. I'm a nurse at Morton Plant. My experience is wound, ostomy, and incontinence, pee, poop, and pus. And we deal with the COVID patients at Morton Plant. It's been a very interesting experience and a trying time for everyone, as well as you guys, but welcome. Thank you.
Thank you, Cindy. Carolyn?
Hi, everybody. I'm Carolyn Rose, and I've been an RN for many years, too many to count. But my background is surgical services, and I have been an operating room nurse, manager, you name it, I've done it. But I've also had some critical care nursing experience, and I've recently worked for the Baycare Health System at St. Anthony's in St. Petersburg and left them, and now I'm working part-time as a nursing instructor at the Pinellas Technical College for the practical nursing program, which I really, really like a lot. The only thing I can share about COVID-19 is what I know from the news and CDC and those guidelines.
Okay. And my double L's.
Hi, I'm Lori Lenhart. I'm a nurse practitioner down at Bayfront in the emergency and trauma room. I've been there 10 years, I guess, going on 10 years. Taking a little break with COVID. We're expecting, so we decided taking a month or two off would be the best thing for our family. Don't show my belly.
Trying to show the belly.
And it's my husband.
Hey. All right, my name is Ben Lenhart. I'm an ER physician over at Morton Plant. I've been there since 2010. And again, we've been members of Calvary for Calvary Chapel. Gosh, what, 5 or 6 years at least?
Yeah.
So.
Yeah, we're happy to help where we can.
Awesome. Well, thank you. And Rhonda, there's a phone number down there without a name, so I don't know if that is who that is. Can you see it?
This is David Roberts. Can you hear me?
Oh, hey, David.
Yeah,
Yes.
we can hear you.
Oh, okay. Yeah, I'm David Roberts. I'm an emergency physician. I work part-time now for Mayo Clinic. I've been an emergency physician for 40 years. Worked for the State Poison Center for 3 years, so interacted with the State Health Department a lot too. So I'll join the rest of you tonight.
Awesome. Thank you.
Good,
All right,
thank you.
Rhonda.
Yeah, so I'm getting a couple of messages here and there that people are trying to log on. Luckily, I'll put this on YouTube, and so they can participate that way or watch later. But so anyway, I'm a little distracted trying to get everybody on here. But let me first say thanks to all of the medical professionals for being here. Thanks for the other members and Friends of Chapel by the Sea for participating tonight. One of the things that I take very seriously as the pastor of the chapel is how we return to worship in the middle of a pandemic, because nothing is more important to me than the safety of our people. And so I want to try to, if I were to state a goal tonight, it would be to strike a balance between the fear on one hand and the laissez-faire approach on the other. So I think there's a middle ground that we can find, and I think hearing from experts, people who are on the ground working and have expertise, is going to be real helpful for that. So are there any other medical professionals on the line that I haven't allowed to be a panelist? And Dave, you are a panelist, it's just that we can't see you for some reason.
I tried, but I couldn't get on with my laptop. I'm on my cell phone,
Okay.
but I can't see any of you. There's a FaceTime log. Oh, I'm not gonna risk that.
Okay, all right. Well, we can hear you, so that's really good. So
Okay.
with that, I'm kind of going to work the Zoom stuff, and we had a survey that we sent out a week or so ago for folks to submit questions, and so I sent that to the panelists. They've had a little bit of time to look at that, perhaps, and kind of respond to the questions that have already been posed. So you're, as a participant, we don't have your video or your audio, but you can post a chat. If it looks like my screen, it'll be down at the bottom of your screen, so you can post a chat to anybody, kind of have whatever kind of dialogue you want to have there. And then the Q&A, I'm kind of monitoring your Q&A. So if you have questions for the professionals along the way, post those, and I'll make sure that your question gets into the discussion tonight. So with that, Carla, why don't you grill these guys and see what we can learn tonight?
Okay, so we'll start with the first question on the list. What have we learned about how the virus is transmitted? Who wants to tackle that one?
Oh, I don't
I
mind
can't
starting.
find it, Cindy.
Okay.
Okay. So obviously it's airborne, transmitted, and by contact.
Okay, so Dave, do you want to expound on what airborne means, or contact? It's both, right? So you want to expound on that?
Respiratory transmission is the most important. Contact is not as common a method of transmission, and it gets complicated when you talk about droplets or aerosols or airborne. It's not really airborne in the sense that measles is, which has a much higher transmission rate, but it is spread by droplets, which can be suspended in the air for various periods. But generally, the droplets settle to the floor, within hours of someone being in a room who's been infected. So it's not a risk that lasts for days. For example, if someone joined in the chapel service who was carrying the virus, it wouldn't remain in the air for long periods of time.
Okay. Anyone want to add anything with regard to that? Okay, so the second question that was submitted is, it says, what are the real risks when in the open air? So I think what that means is if we're outside, is it risky? Do you have a risk factor? Lurane, you want to tackle that since you do a lot of walking?
I will venture to say that my understanding is still to maintain the 6-foot distance. I understand there's some speculation about even increasing that distance to 12. I'm not sure. In my point of view, I'm pretty much following CDC guidelines because I believe we do need to stick with one course as opposed to a myriad of lots of experts. So my understanding is that the masks, I hope this would be obvious to most people, would be that my wearing a mask protects you from me. Related to being outside, it isn't so necessary to wear a mask if people are maintaining that 6-foot distance and not still within a crowded environment. Did that answer your question?
Yes. Lenhart, do you want to add anything to that?
Yeah, I can. Just kind of going back to the whole how it's transmitted. You're right, it's through droplets and aerosol, and it's one of those things that when you say droplets, it's all based on the size of the particle. So droplets are bigger, can contain the virus, but it doesn't travel as far or stay in the air for very long. The whole 6-foot idea kind of came from the idea that some studies showed that a droplet probably goes to the ground within 6 feet. Although it's not something that's 100%. Something that's aerosolized could be in the air for longer than that, and that's why you worry about something being more contagious if it's aerosolized versus if it's a droplet. I absolutely agree. When I'm outside, if I'm jogging and nobody's around me, I'm not wearing a mask. Number one, I can't breathe. Number two, there's probably very, very low chance of catching anything that way. If I'm taking a stroll through the hospital corridor, then I'm going to be wearing a mask because number one, there's a chance that something could be aerosolized and there's people going through there that probably were exposed. So it's safer to protect yourself, but also to protect others. And that's one of those things that the mask, especially the surgical mask, would do, is at least protect you from exposing others if you possibly have been exposed and don't even know it.
Right. Okay, that's and tell us what you mean by aerosolized, because some people may not know what that means.
So the whole idea between something being a droplet versus aerosolized, it's based on the size of the solution. So whenever you say cough or breathe, you have little bits of saliva that come out. It's going to be in a little droplet. Say if you think about fog, if you look at fog, you can kind of see those things suspended. A droplet, they believe, kind of is heavier, it's bigger, so it drops to the floor or the couch or the surface. It doesn't stay in the air. We know that does contain, things like COVID, among other viruses. Something that's aerosolized is just going to be a smaller particle, so it can stay afloat in the air for a longer time. Just like other viruses and, the same thing with COVID, it can be aerosolized. So it's something that may potentially be in the air that could, go further out. So it's based on the size of the particle and how long it actually stays in the air. Droplet is more likely to, they believe, drop to the floor or whatever surface it is within that 6 feet span. And that's why they kind of say, keep your 6 feet distance, because there's less of a chance of contracting something. But again, it's kind of debated. Nobody really has a right answer on that either, but that's kind of the whole 6-foot idea.
Right. And that's also where the contact precaution comes in, the need to wash your hands also, because you could touch a surface where a droplet has landed and then have it on your hand and then touch your face. So
Absolutely.
That's why That's why we wash our hands.
and that's
and
why
I think, go ahead.
I was going to say, just even with droplets and, COVID, it's much less likely to be in the air, aerosolized for a long time, like if you're outside. But that's why with surfaces, they think COVID might be able to last for several days on certain surfaces. And that's why, from droplets or from touching it and then touching your mouth, that's why they emphasize cleaning everything and washing your hands, because again, those droplets or that virus could potentially be on that surface for much longer.
Correct. Awesome. Okay, thank you. All right, and this goes on to talk about mask a little bit. If masks work only to limit droplets, but not aerosol contaminants, is there any real benefit to wearing a mask in public places? So, Carolyn, you want to take that one?
Yes. The benefit, I think, is the fact that you are protecting others from you, because we don't know if we're carriers of the virus or not. I think that's the main thing, is just protecting other people from you.
Right. And also, I think that the droplets are bigger, and even though the N95s and the things that we wear at work protect us from those small droplets, there's still plenty of protection from a regular cloth mask if you're wearing it, and the person that you're protecting, as you said, others from what might be going on with you. And if you sneeze or you cough, there's a chance that a little bit might come out, but you've really done the major protection by having that over your face, your nose, and your mouth.
Mm-hmm.
I think those are real good points. This is Dave again. I think
Hey,
we're
Dave.
wearing masks for each other, not for ourselves. And I think it's important to, when you reopen the church, that everyone feels safe coming into the church. And if everyone's wearing a mask, and that's part of our social contract, then I think everyone can feel much safer. Several studies have shown that about 44% of cases are transmitted by people who have no symptoms. They're either pre-symptomatic and will become ill later, or they never become ill. And so you really don't know who you are and how dangerous you might be. So it's what we do for others. It's not, wearing a mask doesn't really protect us from many particles in the air. They probably block about 60% of droplets, for example, because they're not the tightest fit, but they certainly probably reduce the risk of infection more than anything else we can do.
Right. Thank you, Dave. Cindy, at Baycare, are you all wearing a mask when you're in the hallways and from the time you hit the door as nurses?
Always.
How about the patients? Are they wearing masks as well?
The patients that are positive COVID are now being asked to wear masks when we walk in the door to their rooms. But yeah, everyone's wearing a mask.
Okay. All right. Okay. We're doing the same. Unless we're sitting at our desk in our office, we have to have a mask on. So if I get up to go to the ladies' room or go anywhere in the center, I have to have a mask on. And we just opened our center back to our participants yesterday, and they all have masks on too.
Yeah, that's good.
Yeah. Okay, next question is, what percentage of the population is walking around asymptomatic?
Carla, we don't know.
No, I know. I did look that question up today to see if I could find anything, and I went to the Department of Health website, and all I could find was researchers say 25 to 80% of the people could be unaware that they have the COVID-19, and so that's why we should wear masks, and that's basically all it said. didn't even say what researchers or, what's been done. Does anyone want to add to that?
I can only say at Morton Plant, we had one asymptomatic patient who actually contacted 23 nurses, PCTs, techs, whatever, and several were out for 3 months. Positive.
Wow.
That's a huge impact. You're right. This is Dave again. I tried to research this. It's very hard to find that information. It all depends on how many people you're testing. In Florida, I think we've tested maybe 1% of the population, so it's hard to extrapolate. We do know that the test positivity rate is about 5%. Of all those we test, 5% are positive. But we are tending to test those who are symptomatic or worried about being symptomatic or have had contact or exposure of some kind. So no one knows for sure, but the risk is out there. So for someone to say, I'm not going to wear a mask because I feel fine, that really doesn't make sense on any level.
What I'd have to look at the exact numbers again, but one study I read actually looked at the Diamond Princess, the cruise ship that had the exposures on it. And he said that was an interesting one to look at because it was actually an enclosed space. And they tested everybody, whether or not you were symptomatic or not. And I think they had close to 700 that were positive, and I think they said 300 or 350 of those were completely asymptomatic. So their numbers of the ones that were asymptomatic are 40 to 50%, and that's kind of the only example you have of enclosed space where everybody was tested regardless. It's difficult to get data too, because even when you look at the numbers of people that have been tested, at least in Florida, a lot of those numbers, they're counting people also that have been retested multiple times. So right. You may say that you tested 1,000 people, but you may have a few people that have been tested 10 or 20 times. So it's kind of difficult to get exact numbers with that. But from looking at that cruise ship, out of those 700 positive, there was at least 350 that were completely asymptomatic out of that group.
Right. That's a good point. I know that some of the patients in the hospitals are tested and then retested several times before they get discharged to a facility, because many of the facilities won't take them until there's that negative test. Okay. Let's see. Is it true that Florida is reporting a spike in pneumonia cases? If so, are our COVID numbers being underreported?
Ben, you probably have a better idea of that working at Morton Plant. What do you think about that?
Oh, I have no idea, because we don't let known it's pneumonia versus COVID.
From working in the ER Morton plants, I can't say that I've noticed a significant spike in pneumonia cases. In fact, a lot of the positives that we have had normal chest x-rays, at least to start with. So I really don't know the exact numbers there with Florida. I mean, everything you look at recently, it seems like the COVID levels have been fairly consistent. They haven't really had a major spike in COVID cases. I would say that the testing has become better, which, if we're seeing a spike in COVID cases, a lot of that is also because you're testing more people and the sensitivity of the test has become better over the last few weeks.
Mm-hmm.
And they're going to test people with pneumonia.
Yeah.
All right. So then somebody asked a question about what is the situation in our local ICUs? Do we have adequate personal protective equipment locally?
It's Cindy again. I would have to say our small little department, when they go in to ask another N95 mask, sometimes we're getting them fine, and sometimes they have none.
Yeah. Then what about you
Teresa-
in the ER?
Oh, I'm sorry, I didn't.
Oh.
With us right now, we have had significant improvement over the last several weeks. Again, when everything first started, we were reusing N95s, reusing masks, we were cleaning them. Any sterilization process you could think of, you would do. Now, I at least have a new N95 every shift I go to. So now it's significantly improved compared to when this crisis first started.
We also have had improvement. We are still reusing the N95s, and we were asked to reuse our surgical mask, but we've gotten a better supply, so I'm allowed to give them out more. But we're counting them. They're locked in my office and they're doled out. That's why they say too that the public should wear a cloth mask and leave the regular mask to people who are working in the health field. Anyone else want to comment on that?
Yeah, I think maybe the congregation is looking for some reassurance that there's still bed capacity. And from what I've read, and I called Morton Plant today, it sounds like the occupancy rate is probably no more than 60 or 70%. Maybe Ben would know better.
Yeah, it's by no means are we at where, say, New York or other states are at. I think the isolation initially really did help flatten the curve. We were prepared for, a big surge of COVID positive patients. We, basically took our emergency department and cut it in half, and one side was only for respiratory, the other side was for other complaints. Now we've been able to cut that down to maybe a quarter of the emergency department is for respiratory, isolation, and even that is not at, capacity. And same thing with the ICUs. It's something that we certainly are not at full capacity by any means. I think that the isolation really did help flatten the curve with that.
Part of the question was about the ICUs. I called Morton Plant today, and the person I spoke to said that there were 3 ICUs at Morton Plant with at least 20 patient capacity in each one, so at least 60 altogether. And right now, only 16 of the 60 are occupied by patients with COVID-19. A total of 165 inpatients right now have COVID-19 at Morton Plant, of which only 16 are in the ICU.
That's actually more with, it'd be with Baycare as a whole. That's not just Morton Plant. So that'd be multiple Baycare hospitals.
Oh, well, that's reassuring. Those are pretty low.
That's more of what the approximate numbers would be, I would assume, for all of Baycare, not just Morton Plant as an isolated hospital.
Mm-hmm.
Okay.
Okay. The next question we had was, taking routine temperature checks has become a standard in long-term care facilities. That's what we call, that's a nursing home, and some businesses. Since many elderly people have a normal temp of 95.5 to 97, at what point do you consider they have an elevated temp for COVID-19 concern? Well, first, I just want to say that I don't know where that normal came from. Maybe axillary if you take a temp under the arm, but geriatric people have the same, elderly people have the same temperatures that all of us do. Somebody may have a lower set point. They always are at like 97.5, and so they can tell you if they're at 99 that's really high for them, but most of us have a normal temperature. So I just wanted to make that comment, and I'll turn it over to anybody who wants to answer that about when would you become worried with an elevated temp?
I think that's pretty easy to answer. At least there's consensus. According to the CDC, the temperature has to be 100 degrees or higher. So it was revised downward from 100.4. It's 100 degrees even Mayo Clinic changed its criterion to 100 degrees based on the CDC. And that was another question too, what people turn to information they can trust. And I think the CDC is probably the best source of information for in the United States. Centers for Disease Control.
Okay. And so we're taking temps at work on all employees. You have to have your temperature taken, and you have to sign it in a book and initial it so I can show it to ACA if they come knocking on my door. And of course, we've been taking it of all the patients when they come in, even if they're just coming in for a clinic appointment and they're going back to get their vital signs taken. We still take their temperature as soon as they get off the transportation bus and into our center. Are you all doing that at Baycare? Are you taking temperatures?
Absolutely. It's Cindy.
Yeah. Staff too? Staff and employee, or staff and patients when they come?
Absolutely.
Okay.
Yeah.
At our dialysis clinic?
Oh, yes, Sharon, what's going on there? Are you doing that?
Well, the staff has to take their temperature as soon as they hit the door. The patients, before they get in the door, we take their temperature, hand them a mask. They're masked as soon as they walk in. Anything over 100 degrees, we can't bring them in amongst the other patients and dialyze, and we send them to the hospital.
At Mayo Clinic, we're told to check our temperature at home before we even report for duty. But at the door, our temperature is checked again. If it's 100 degrees or higher, we're sent home.
Right.
100 seems to be the number.
Yeah. Okay. With such a wide variety of opinions regarding when to take next steps and which steps to take, what criteria should one use in choosing the individual from whom to receive counsel?
I think I've indicated. Go ahead.
The CDC, Dave, is that what you were getting ready to say?
Yeah, again, the Centers for Disease Control, they have a long history of reliable and expert data. So yeah, and they're under political pressure too, but they're withstanding it pretty well. I would trust them more than local or state health departments.
Right, and if you have a PCP, a primary care provider that you go to, or your doctor or your nurse practitioner, they're always a good resource if you're concerned about something, because they stay, like, I know y'all probably get the same thing. We get daily blast from the Department of Health and from our leadership teams, giving us the latest information, maybe changing something we're doing. I know in the beginning that COVID screening tool that we get from the Department of Health, that changed almost every day until, it's been pretty steady now since about the 6th of May. But your own doctor is a good resource to call the office and say, whatever question or concern you might have heard something on the news or saw something on Facebook that gives you concern and you're not sure if it's real news or not, or if it pertains to you and your health, what's going on with you. So the best person to call is your doctor or your nurse practitioner.
I think that's a real good point. Often you can get that information on the phone and don't even have to for a visit. But some of the complications, maybe ask yourself, I have heart disease or high pressure, diabetes. Am I higher risk if I come on Sunday? Well, that's something you could discuss with your regular doctor.
That's right. Did anyone want to add to that? Did you all hear what Dave was saying? He broke up a little bit, and I just want to kind of reiterate what I think he was saying. Your primary care provider knows your own personal health history, and that's really the person you should check with to see if you should risk coming to church. And here are some of the things that you would be concerned with: over 65, diabetes, morbid obesity, immunocompromised, meaning somebody that's had cancer, HIV, had an organ transplant, takes steroids for some reason, has renal disease or kidney disease, heart disease, liver disease, somebody who's pregnant, and somebody who is homeless or has lived in incarceration for a number of years. So those are things to consider that you would be challenging your body if you were to get COVID.
I have a question that relates to one that we just kind of moved past. It's related to temperature. It says, I take my temperature daily. It's always 95 to 96. So when do I have a fever?
Yeah, you know, that's an interesting question, because patients have told me that or asked me that for years in the emergency department, claiming that they're really sick because their temperature is 98 degrees and it's usually 96 or whatever. But the simple answer is 100 degrees is really the cutoff. And temperature varies throughout the day. But to argue that you're sick because your temperature is a degree or two above your usual temperature really doesn't hold much validity.
I have another question here for something that we just kind of moved past, kind of, I think, sort of related to who can we trust for information. This is from Russ Stauffer. Since we know limited facts dealing with transmission, why hasn't it been mandated for mandatory wearing of masks?
I think it has been. There are businesses that have said you have to wear a mask to come in here. It's mandatory in my work environment. Cindy says it's mandatory at Baycare. Sharon, you've said it's mandatory. You're wearing a mask too, right? And your patients. So I don't think, you know, if a private business says you don't have to wear a mask to come in here, that's their right. Whether you want to go in there and participate in the business is your right as well. Anyone else want to add to that? I'm just hogging that question.
Cindy, I would have to say you're not being smart if you do wear a mask.
Yeah, I think the evidence for wearing a mask is very strong. There's some questions where we can say, you know, no one knows, and no one can really give a strong opinion. But I think this issue is settled. Wearing a mask does protect you and others from catching this virus.
Carolyn Rose, you were going to say something.
I was. Well, I just was at a business establishment over the weekend, and they're very adherent to the guidelines because they've just reopened and they want to stay open. So they're going to follow CDC guidelines. I had to have a mask on when I walked in. I had to wash my hands before they even started my service. So I think most business owners are very adherent to the guidelines because they want to stay open and make some money.
Now, I went to a doctor's office today and there was one person out of 10 that had no mask on. And I'm like, really?
And I think we have a responsibility to make everyone feel safe when they come back to church on Sundays, that everything reasonably possible is being done. So I can't imagine the church reopening without everyone wearing a mask. It's probably the single best thing we can do to prevent the transmission. It's not a guarantee, of course, but it's going to reduce the risk more than probably anything else we can do other than social distancing. And the other thing is all of this tonight is, the point of all of this is to decide when it's safe to start having, you know, services together again. And that's why we're trying to reach a consensus. And I think it's inevitable that someone in the congregation will, you know, come down with COVID-19 in the coming months. one or more. We have to be able to live with ourselves. If that happens, we won't know whether they caught it during a service or elsewhere, but at least we'll know that we did everything reasonably possible to reduce that, risk of happening at the church.
So Rhonda, you've taken measures regarding reopening, masks, walling off, pews, cleaning. What else can you let people know?
Yeah, once we make a determination of when we're reopening, we're going to do a whole big communication about this. But we've bought pew ropes. Every other pew will be roped off. We bought 6-foot dowel rods to put in the pew. So when you and your family sit down, you can put the dowel rod next to you so nobody sits 6 feet. We bought offering boxes to hang on the wall so they're touch-free. We bought prepackaged communion elements. So you pick it up when you come in. Only one person has carefully handled it. Maybe me, I don't know. So you'll pick it up. It has a communion wafer in there and a little shot glass, right, of juice. If you need wine for your communion, you're going to have to bring your own, but just a little. We're going to have ushers. We're going to have to do an usher training. We're going to have ushers at the entrances. We're going to limit entrance to 1 or 2 doors. Ushers will be there with hand sanitizer. We're not going to do orange juice or have any sort of food event for a while. Singing is a huge deal, and we're taking precautions around singing, but let's talk about singing for a minute. And Carla, I may have jumped the question here, but since I was put on the spot, can you guys talk to me about singing and talk to me why I'm hearing that singing is one of the most dangerous things we can do together?
You're aerosoling when you sing. When we're taught to sing, we come up into the mask. So we come up from the deep lung. If we're singing properly, we're using our diaphragm and we're spraying out our words. It's the same. It can be the same as a cough or a sneeze as far as shooting out the air from our mouth. Carolyn can probably add to that for me a little bit.
Well, that was my understanding as well. Much as I hate to say it, because you all know how much I like to sing, that's a real concern. But going back a little bit on people that come into church and then a few days later they're feeling ill, they go to the doctor, they test positive, and how do we handle that from a legal perspective as a church congregation and the church board? Has anyone thought about that?
That's a good point. Yeah.
We have, I've got Brian kind of looking into that with our insurance agency. And I don't know the answer to that just yet. I don't know. Is Brian around there, Sharon? He may have gotten an answer by now, but yeah, we've considered that. And the thing is with this thing, when we gather back for worship, we're going to be living with an amount of risk. And it's a matter of how much risk are we willing to live with? We're always living with some. Every time we open our door, somebody could trip and fall and whatever. But so we're always going to live with some risk. So we're just going to have to be comfortable. If we're going to gather for worship, we're going to be assuming some risk.
Brian's here. I'll check with him.
Okay.
The other point is contact tracing. We haven't mentioned that yet, but it might, ideally, we should track who's at each service so that if we find out later someone was sick, even a visitor from another state, we'd be able to notify, contact trace everyone at that service. So that would be the ideal, course of action. It would involve a lot more work. I don't think there's any legal obligation to do that, but it would make the job of the contact tracers easier. And just one more thing that might reassure, parishioners who are considering whether to come back or not. Imagine if you took an airplane flight and there was no log of the passengers, and someone was sick and there was no way of notifying all the other passengers on that flight. Similar to that.
However, this is Cindy again. If you've got people who are coming into church for the first time and they've been to Publix, Kmart, blah, 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 you don't know
Right.
the contact of this.
That's right. That's where it's their history of where they've been, if they've washed their hands, if they wore a mask, who they came into contact with, we don't know. And so that's the risk we all take when we decide to go somewhere. And then that's why we have to say what we're comfortable with. Are we comfortable with going? And if we are, under what conditions? And do we want everybody to follow those conditions?
Tell me this, Carla. Have
Yes.
you gone out for dinner with Joe?
We did once, and we were just not comfortable. And it was our favorite little place. And we wore masks in. We took them off to eat. We put them back on. And the waitress we felt got too close to us. She's too friendly. And of course, I start thinking she did it she gets too close with everybody. And so, yeah.
So Rick and I have not gone out once.
Yeah. Just the one time we did.
Okay.
Of course,
okay,
we're old.
So,
we're in the high risk group.
Yeah. So people aren't really comfortable yet.
A lot of people
Okay.
are.
Okay.
So there's
Rhonda?
no question. Yeah, Sharon.
Brian said that no insurance company covers communicable diseases.
Great.
Fabulous.
All right. There's another question in the Q&A. What do we know about the virus mutating? What about heart issues?
That's one of the hardest ones, I think. No one knows is the short answer. This virus could do anything it wants. Some people are speculating there'll be a second wave in the fall, like in 1918, but that's pure speculation. There's a chance the virus doesn't come back, but it's not disappearing like the influenza virus. That season was officially declared over, I think, early May or late April. But we're seeing lots of cases of the coronavirus, so it doesn't seem to be respecting summer. Where it goes from here is anyone's guess. It's interesting, if you study the history of the 1918 flu epidemic, the first episode was actually in the spring of 1918, and that was no worse than a bad flu season, but then it came back in the fall and killed people by the hundreds of thousands because it had mutated in August to a more virulent strain. And these viruses are unpredictable. They could mutate at any time. So it's speculation. There's no answer, unfortunately. But if I could make this make a momentary digression, I would urge everyone to get a flu vaccination in the fall to at least protect yourself against a disease where there is a vaccine, and so you're not weakened by ordinary influenza and perhaps more susceptible to the coronavirus. That would be the worst case scenario, where they both start again in the fall together. And also, this is a window of opportunity to get your kids vaccinated. A lot of us got behind because doctors' offices were closing. So if there's another wave in the fall, it may not be possible to get all the vaccinations your kids need. So I would urge you to take advantage of the summer and catch up on every immunization possible.
Just to add to
Pneumonia
that,
too, right? If you're over 65, pneumonia vaccine.
Oh, that too, right.
Dave, or Ben, what were you going to say?
I was going to say, just to add to that, with the virus mutating or coming back out, again, like everybody was saying, nobody knows. When you look at coronavirus in itself, I mean, there's at least 7 or so different coronaviruses, out there. It's not like this is a first time we've seen a coronavirus, but it's a different type of coronavirus. You look back at SARS from early 2000s. I mean, that's a type of coronavirus as well. You look at other viruses like Ebola, I mean, where we had that outbreak, just not as severe. I mean, these are all viruses that, if it's not COVID-19, I mean, it's going to be a different virus or a different coronavirus that, you know, has a potential to come out at any time again. So this coronavirus is not, I mean, it's a new virus, but coronavirus, you know, there's multiple different coronaviruses that already exist. So again, nobody can predict, but if it's not this particular coronavirus, I mean, there's always a chance that any virus can come back out.
Well, if we can, take the last few minutes, Carla, to kind of shift our attention to reopening for worship. I think your last question, I kind of jumped in there, but what needs to be in place before everyone who physically worships in the chapel can do so safely? This includes the pastor, thank you for whoever asked that, and other celebrants during worship. Let me tell you the other things. I got sidetracked. So with the singing, Ron Neal is actually working on building plexiglass boxes so that he can station maybe up to 4 singers eventually, maybe 6 singers within plexiglass boxes in the choir loft. What else am I forgetting? Touch-free everything, ushers at the door. Hand sanitizer, mask required, is something we're looking into. Is there anything else that you as medical professionals can think of that we're forgetting?
Do we need gloves? It's Cindy.
Requiring
no.
gloves? What's that?
Gloves?
Do you think we need to wear gloves? I haven't seen that as a CDC recommendation, so I haven't been thinking about gloves, but do I need to think about gloves?
I would say no.
I would too.
Yeah, it's one of those things that I think hand sanitizers, washing your hands is going to be more important. I think that people often wear gloves and think that they're safe, but you're still spreading whatever you touch just as much as anybody else. Often you would get something just from not taking the gloves off, you know, the way that you should. So I think that people kind of, if they wear gloves, you're going to spread things around, and you're probably not going to clean your hands with hand sanitizer or wash your hands like you probably should. So I think it's actually probably safer to forego the gloves. I think that everything else you guys have mentioned, you know, have somebody doing temperature screenings. If you have masks to hand out, surgical masks at the door, I think would be fantastic. Spacing the aisles out. I think that, you know, you're doing above and beyond which most businesses are doing right now.
Mm-hmm. I think the other thing people just need to be more cognizant of is don't touch your face. Don't touch your mouth, don't touch your eyes, don't touch your nose, because if you've washed your hands and dried them properly and then you touch a doorknob and then you're touching your face, there's always—
You know how many times I touch my nose a day?
Everybody does, but I just wanted people to be aware of that.
I don't know, it sounds like a personal problem to me, Cindy.
I know, it is a personal problem.
The other advantage of having a mask on is that you can't really touch your nose or mouth. It discourages that behavior.
That's right.
It does, absolutely.
That's right.
All right, kind of I'm going to hit you with 2 questions about reopening for worship. Number 1, I've read that church is one of the most high-risk activities you can engage in. Why is that? That's my first question. The second one is, with most of our population being high risk, 65 and over, with commingling, you know, indicators for COVID, what would you recommend to folks in the high-risk category about resuming worship? So 2 questions, go.
What was the first part again?
First part is, why are they saying, why have I read here and there that church is one of the most high-risk activities?
Because it's hugging, it's touching, it's close. The singing we talked about, the group reading is the same as the singing almost, not quite as bad, but you know, when we read together, that would be my opinion about that, is that's why. And now I forgot the second part.
I think there's also the duration of people being together in that space for an hour. That the duration of time is also an issue.
That's correct. Absolutely. Absolutely.
Could we possibly ask for volunteers for maybe 25 people to come on X date to start this?
Yeah, I plan to. The board has actually talked about having a soft opening with the board present, as well as maybe people who are, I would want to invite ushers so that we can have an usher training on that soft opening day.
Okay, okay.
The other thing to add to just with keeping everything safe is like somebody mentioned just about being at church, you want to shake hands, you want to hug, it is close. I think ahead of time, just kind of making everybody aware of, even if you want to go shake somebody's hand or give them a hug, don't do it. You know, say hi, say whatever you like to say, but, you know, try to discourage, you know, for the time being, the actual contact is going to be important.
Great.
I'd just like to add that maybe temperature screening at the door is a little overkill. If everyone's wearing a mask and they're using hand sanitizer as they enter the church, ideally people would, if they feel any symptoms at all, would check their temperature at home and come to church if it's degrees or higher. But be able to do that reliably at the door, you'd have to purchase one of those thermal sensors. I think they're like $250. And what if it stops working, or the batteries go dead, or if you get a reading of 100 degrees and you think it's a false reading and you repeat it and it's 99, which one do you believe? And sending people away at the door is problematic. So I don't know how the rest of you feel, whether that should be a routine if we have Sunday services, but I don't feel strongly about it. The other point is, if someone had a temperature of 100 degrees, the likelihood would be that it would be something else other than COVID. And many people with COVID don't have a fever, or they have a fever intermittently. So it's not going to capture everyone with COVID. It'll capture a lot of people with other trivial illnesses.
And you don't feel good, Dave, with a temp of 100. I don't.
Well, a lot of people don't even notice it. If it's low grade, but it's a practical issue. It's the other unintended consequences, you people bunching up at the front door because they're waiting for their temperature check, and then they're, you know, congregating together.
Sure.
So it could backfire. Yeah. You want people coming in and moving along, not packing up together.
Well, our time is up. Let me close with a couple of things. First of all, is when we gather for worship again, I'm going to do my best to communicate that it's not going to be like normal. And so it might not even be terribly enjoyable if you've got to, you know, wear a mask and we're not singing and we're not hugging. It's going to be different. And so I'm trying to communicate that to people. So not to expect the same warm fuzzies that we're used to feeling when we go to church. It's going to be a little different. And that's just going to be where we are during this time until either there's herd immunity or vaccine. Because we care about each other and we don't want to make each other sick. And I like Dave's phrase that we have a social contract. And so the board is going to be, I'm going to encourage them, if they're not on right now, I'm going to encourage them to go back and listen to this if we post it on YouTube, and so that we're kind of on the same page. And and with that, let me give my thanks to each of the panelists. I appreciate you giving your time and your expertise to your church family. Thank you so much. I appreciate each of you being here tonight. And to Carla, especially for helping facilitate this. So I was kind of trying to manage the Zoom and kind of throw it on Carla. Thank you so much, Carla. And thanks for all your work.
You're welcome.
Great job, Carla.
My pleasure. Thank you all for joining me.
I know. Yeah. Lurane and Joe and Linda Sorum are working on a wellness, and I think Carla may be participating in a wellness program coming up. So kind of pay attention. That'll be coming out in the weeks ahead. So keeping safe and keeping well. And so with that, Dave, you want to tell us about the hole-in-one you got this week?
Yeah, that was a blessed event.
So a little good news there. Dave got a hole-in-one this week. So way to go, Dave. Let me close. Go ahead, Dave.
Don't tell them how short the hole was.
Okay, fair enough. Well, let me close in prayer, and we'll get on with our evening. And the board will meet on June the 10th. We're collecting the survey responses. The board will meet, kind of review this survey responses, make an informed decision, and we're going to just hold whatever decision we come up with in prayer and go forward and trust in God's goodness. And try to be safe with our social contract that we put in place. So any last words from the panelists before I say a prayer?
Rhonda, I would just like to thank you for your leadership in terms of really shepherding our church family. It's been really inspiring to see how hard you've reached out to really problem solve. How are we going to do this? How are people going to connect? Where are we touching people? Where are we not? Where might there be shortcomings? I'm really grateful to be a part of this church. I'm grateful for you to have shown your incredible leadership.
Thanks, Lurane, and I'll pay you after the meeting.
And thank you, Rhonda, for keeping Rick and I on the phone with the computer today.
We got you on. I didn't get you on.
Kristen, you did great.
All right.
And if I could just add a really quick thing, you know, we've all participated, everyone here, in one of the Zoom classes or choir or something. Please do that. I know people better from these Zoom classes than I did seeing you in church, and it's very enriching. And thank you you did spearhead that, Rhonda, for all of us, and we so appreciate it. So, you know, if you're not comfortable coming to church, that's a-okay. We will keep things going in like this.
That's right. Thank you for saying that. We are going to do a hybrid of everything, worship as well as classes. I think Joe is on the line. Joe's done a layman's work of getting classes up online and running. So my thanks to Joe. Ron Neal is on here too, and he's been working hard to keep the choir engaged and trying to be creative about how we can have some singing when we come back. So my thanks to my staff who've done a great job. All right, let me say a prayer so you guys can get on with your evening. Let's pray together. We give you thanks, O Lord, for Chapel by the Sea. We give you thanks for the men and women who have come before, whose shoulders we stand upon. We give you thanks that they weathered storms and will weather this one as well. We pray for wisdom, O Lord, as we seek to know the best way forward, the way to both be community and to keep each other safe all at the same time. So we pray for one another in our time of need. We pray for our country in our time of unrest. And we pray for these folks, these medical professionals on the front lines. Keep them safe, keep their families well. Thank you for their ministry of health and healing. God bless them. And in Christ's name we pray these things. Amen. Thanks for being with us today, everybody.